All right, moving on. Next, we are going to hear about medical oncology updates and new treatment options, and I would like to welcome Dr. Leena Gandhi, who is an associate professor in the departments of medicine, the director of the Thoracic Medical Oncology Program at Perlmutter Cancer Center. There's a pointer if you need it.
Well, thank you for the opportunity to be here and speak to you. You heard from, I think, the most amazing group of people I met a little earlier this year, the lung cancer support group, but it's a great group of people. Sorry. You've already heard a little bit about this, but I just wanted to introduce sort of how serious and difficult a problem lung cancer has been for all of us in trying to make improvements over the many years that people have been working in this area. It is still the #1 cause of cancer death in the world, higher than any other type of cancer, even though it may not be the most common cause of cancer. And one of the serious problems, although there's been clear advances that you heard about from Dr. Michaud in actually diagnostic and interventional techniques, and you'll hear about surgical techniques from Dr. Cifolio, unfortunately, more than 75% of lung cancer is still not curable with surgery alone. More than 50% of lung cancer is metastatic or not treatable with anything other than medical therapies to control the cancer at the time when it's diagnosed. So we still have more to do in actually trying to do early detection of lung cancer before it has progressed, and also make more advances in actually treating cancer even when we can't cure it. We don't cure a lot of things in medicine. We don't cure high blood pressure or diabetes, but we have very, very good treatments that can keep people alive and well to live their lives. And I think that's been something that we've been struggling to do as well in cancer as in other areas, but it's something that we're made a lot of headway on, and I'm going to talk a little bit about that today. And one thing I think you heard about from Dr. Michaud is also that in this day and age, lung cancer is more than a smoking-related phenomenon. Although smoking is a risk factor for lung cancer, 20% of lung cancers that happen in women happen in people who have never smoked. 10% of cancers that happen in men are in patients who have never smoked. We have more to understand about what are the causes in those settings, and also they lend different opportunities for potential treatments as well. So in the past, chemotherapy was really the mainstay of all treatment, and the problem with chemotherapy was not just that it may have side effects or that it is kind of a sledgehammer approach to therapy, but that it really was done in a one-size-fits-all way. Lung cancer was considered all one thing, and everybody got the same treatment, no matter who they were. And that's, I think, was a fundamental problem that has dramatically changed in the last 10 to 15 years since we've been able to get techniques that can enable us to look actually at the molecular or DNA characteristics of a cancer and understand actually how different cancers are in different individuals. Everybody's cancer is different. It is not the same as anybody else's because it arose within your own individual body. That understanding also affects the way that we develop drugs and develop treatments for cancers. In the past, a clinical trial tested the same drug in all patients in the same way. And the goal of evaluating a drug was, well, let's try to get to the maximum tolerated dose before the side effects are too severe and we can't really use it successfully, which is a terrible way to develop drugs, as you might imagine, and has led to, therapies that are not easily tolerated, and everybody is different, so your maximum tolerated dose is different too, and it doesn't necessarily, by being tolerable, doesn't mean it's necessarily more effective. The future, and I would say the present, is much more focused on an individualized approach, and I think we'll get better and better in this in the future because we have more and more techniques to understand individual differences in patients' cancers. And a lot of the focus of current research is really trying to find the best, what we call biomarkers, or ways to differentiate one person's cancer from another so that we can actually tailor treatment to be really meaningful and hopefully more effective for you as an individual. Now our clinical trials goals are really about more of an optimum biologic dose. Where's the dose that we're actually getting effectiveness to a therapy in a specific type of patient where we're actually going to make a meaningful difference? And there's been, I think, with these advantages in diagnostic techniques and actually understanding the DNA changes in a cancer, we have a much more recognition that lung cancer is very heterogeneous, and we need heterogeneous approaches and individualized approaches for every patient. So Now we have many more options to treat lung cancer. Chemotherapy still plays a role, and an important role in the treatment of lung cancer. It can be effective at really managing symptoms and controlling rapid growth of cancers. Angiogenesis inhibitors are another important way that we can control growth of cancers. These are drugs that actually affect how cancers tell blood vessels to grow into them to be able to feed themselves. But what I'm really going to focus on today is targeted therapy and immunotherapy, where I think we've made the most meaningful strides in the last 10 years. And those strides are really changing more and more rapidly month by month. And targeted therapies are, I think, best exemplified by EGFR mutant lung cancers, which is about 15% of all lung cancer in North America. In Asia, actually, it's up to about 40 or 50% of lung cancer. But the way we learned how to really differentiate treatment effects was from our experience with treating patients with EGFR mutations. And what we learned is that when we first developed EGFR-targeted drugs, they were used in all patients in the same way, one size fits all. But when we kind of tried to look at, well, actually, only some people are getting benefit, but some people are getting major benefit. And those were patients who had a particular type of lung cancer, mostly patients who did not have a long smoking history. It was more common in women, more common in Asians. And we went back and tried to look at those patients' tumors who were getting benefit from this drug. Then we found these sensitizing EGFR mutations, which is what helped us identify, well, this is the marker of whether this drug is actually going to be effective. And now these drugs are developed from the very beginning in patients who have these mutations. So if you are trying to target an EGFR mutation, you target it in those patients from the beginning. You're not really testing it and developing it in patients who are unlikely to benefit from it, and hopefully you're really focusing, trying to understand who's most likely to benefit from the very beginning. And the same goes for as we develop more and more drugs. We know that people can develop resistance to these drugs, and we need to develop more drugs to overcome that. And again, in those specific patients is where we're going to have the most success. From that experience, and this is an old slide still, but it sort of shows you, again, a little bit of the evolution. Before the recognition of EGFR mutations, the only thing we knew about was KRAS in lung cancer, which is a driver of lung cancer growth, but it's something we've not been able to develop effective therapies for yet. But in the ensuing years between the 80s to 2013, we've identified many, many different subsets of lung cancers, many, many different heterogeneous types of lung cancers that are driven by individual genes that really get altered and somehow drive the growth of the cancer in that individual. And for most of these, we now have targeted therapies that can be extremely effective, far more effective than chemotherapy at controlling cancer with minimal side effects and keeping the cancer at bay for much longer. This piece of the pie is getting smaller and smaller each year. Each successive year, we can find more and more things that even if it's for a very small percentage of patients, such as RET or ROS, which are present in about 2% of lung cancers, we have effective therapies. We want to figure that out for an individual right up front so we can give them the right therapy from the beginning. And this is actually just an example. This is from the Lung Cancer Mutation Consortium, which is a consortium of institutions across the U.S. that actually started after the discovery of EGFR mutations about 10 years ago to systematically try to identify what are drivers of lung cancer growth and can we develop drugs specifically for those for specific patient types. And you can see that these are all the different types of things that we have developed good targeted therapies for. There's still a group that we're working on, and this bar keeps going down year by year because we are identifying more and more subsets of patients for whom individualized therapies work better. Ultimately, though, I'm sorry, I think I lost a slide in here. But ultimately, targeted therapies are not cures. They are definitely very helpful drugs at controlling cancer. But like infections can develop resistance to antibiotics, almost universally, people over time develop resistance to targeted therapies. And while we work to develop new drugs to overcome that, what we'd really like to be doing is something that can hopefully change the overall long-term outcome for patients. And that's where, in the last 5 years, I think we've made the most strides in the field of immunotherapy. And immunotherapy is not a new concept in treating cancer. We've, for a long time, hoped that we could use what our body's natural mechanism is to target abnormal things and get rid of them, which is your T cells or immune cells that basically kill abnormal things, to kill cancer cells. And we know it can happen. We've seen many examples over the past more than 150 years that we've been studying this in cancer, where immune cells can effectively kill cancer cells. We know that, that immune cells can recognize cancer cells as, quote, foreign, because they often express proteins that are not expressed in normal cells, and that can serve as sort of a signal that, hey, I shouldn't be here, please kill me. The problem is that cancer cells are derived from your own body's cells, so they can mask their differences, and they can very, very subtly blend in with the rest of your body, and sometimes not be recognizable. They can be what we call cold tumors or unrecognizable tumors to the immune system, as opposed to hot tumors, which might have a lot of signals and are considered immunogenic. So intrinsically, although we've always thought immunotherapy in lung cancer and any cancer would make sense, in the past it has never been very effective to try different therapies. And many different therapies have been tried, including vaccines, things that can stimulate the immune system. The difference really in the last 5 years is trying to, as we understand more about how different cells in the immune system work and signals in the immune system work, trying to basically lift off some of the brakes of the immune system. And that's what PD-1 or PD-L1 inhibitors do. PD-1, which stands for programmed death 1, is actually a receptor on immune cells that basically regulates the immune response. So if you get a cut and you have a very robust immune response to heal that cut, you then want to turn it off once that healing is done. So you want to suppress the immune attack on things and development of inflammation. So after this recognition occurs, you want a tight regulation of your immune response to any given situation. Unfortunately, cancers can co-opt that mechanism of regulation and express this protein called PD-L1, which can basically turn off immune cells. And this might be one explanation for why vaccine therapies and other types of immune therapies in cancers have never been that successful in the past, because maybe once you get to the actual tumor site, the tumor has a way of turning off the response the immune response to the cancer and protecting itself and keeping itself alive. PD-1 or PD-L1 inhibitors have been what we think are phenomenally successful in lung cancer, because for some patients, they have led to not months, not a year, but years, many years of benefit. And we still don't know actually how long those benefits can last, because the drugs are still new. But we've certainly, I think we all have stories of patients who've been living for 8 or 9 or 10 years with metastatic cancer, having been treated with immunotherapy. The problem is they don't work for everybody. And overall, the chance of benefit really is only in about 20% of patients with non-small cell lung cancer, the most common form of lung cancer. So although there are multiple drugs that we're now actively using in the clinic, either as subsequent to chemotherapy or instead of chemotherapy, we still aren't effectively treating the majority of lung cancer patients with these drugs. And we also know that although they're not like chemotherapy, and that most people have some degree of side effects. Most people actually with immunotherapy don't have side effects, but some people can have rare but very serious side effects, which can in some cases be life-threatening. So while I would say we're at the beginning of a new era and trying to use immunotherapy to really make it a very tolerable, long-term effective therapy that can lead to long-term survival for patients with metastatic cancer. And what we'd like to do as a next step, and the research that's really going on now, is how do we broaden this benefit? How do we get this benefit to be in far more patients than 20% and really all patients? And that comes back to this question of biomarkers. The reason we were so excited for so long about targeted therapies is they provided a way to say, if we know this about your cancer, if you carry this EGFR mutation, you're 90% likely to benefit from this drug. This is the right drug for you. We don't yet have that kind of a biomarker for immunotherapy. We know that high levels of PD-L1 expression can be a predictor for benefit, but it's not a black and white like EGFR, and nor is it a fixed genetic change. PD-L1 is a dynamic biomarker, meaning with your own body's exposure to the environment, to your life, to different therapies that you might experience, those things can all change. So when we try to study things and, well, what's going to predict whether this is going to work, sometimes we don't know what we're looking at because we might be looking at the wrong slice in time. PD-L1, this is an example of what PD-L1 staining looks like on cells. These are cancer cells, and the blue is actually just staining DNA, so there's no staining here. This is a patient where there's no PD-L1 expression. Does that mean that patient could not have any benefit and we should never use these drugs for them? Not necessarily. There are still some patients who have no PD-L1 who still get benefit from these drugs. And there are some patients along all these spectrum, the brown is very intense staining, who can get benefit. we do think that patients here are more likely to get benefit, but it's a gray area. It's by no means black and white. Part of the problem with that is when we do biopsies of the kind that Dr. Michaud talked about, we're sampling one tiny area within a cancer. And there might be uniform expression of PD-L1, so we'll get an accurate picture, but there might not be. And we might put the needle in a place where there isn't PD-L1, but there's lots of PD-L1 right next door. And that patient might still respond, but we didn't get the right biomarker. Or the PD-L1 is in the tumor cells that are right next to the immune cells. Those are these pink cells at the edge of the tumor, and we don't get in the right place. So we just don't get the right answer from when we're trying to do these tests and say we should or should not use a particular therapy. So we have a lot to learn, and I would say a lot of our research is really focused on both biomarker development and also combinations, which I'll come to in a minute. But I just wanted to use this illustration, which was given to me by one of my colleagues in Boston that I have worked with for about 20 years. But I think it's a very good illustration of the types of therapies that we use and how they're different. If we think about cancer and growth of cancer as a car driving very fast, what chemotherapy was in the past was really, like pouring acid in your engine. It's just sort of a very non-specific, non-individualized approach to just try to kill everything there, but the problem is you kill the good and the bad at the same time. And that's what that's supposed to sort of represent. Targeted therapy, though, is actually really targeting the driver's seat, targeting what's really driving the growth of the cancer. And for some patients, we can identify that. For patients with EGFR mutations, ROS alterations, ALK alterations, but for many patients, we still can't. There may be more than one driver, if you will, and there may be many different things that are actually driving the growth, and targeting one thing may not be sufficient to really stop that car from continuing. And I think that the analogy that Dr. Barbie, my colleague, made of immunotherapy is that cancers usurp your body's normal signals to basically create a force field around themselves. By expressing PD-L1, they block immune cells from getting in and killing or stopping the car from going. And when you block that interaction with PD-1 inhibitors, you can sometimes get these T cells into the right place and get them to kill the cancer cells. So what we know about immunotherapy is you need T cells in the right place to be able to kill them, and then you need to get rid of the signals that might block that effect from happening. But again, and I'm sorry, I missed one slide earlier, so I'm going to just explain to you where I think we are now is that if we thought about metastatic cancer as people over time die of cancer, what we're trying to make differences is drugs that keep people alive and well. And we did make some headway with targeted therapies because those people who get benefit certainly live for longer and do better and live better, but ultimately they develop resistance too and may still die of their cancer. What we'd really like for everybody is what we call this tail of the curve, which means that there's a certain proportion of people here with PD-1 inhibitors who just keep living for a long time. They have immunity now against cancer because their immune system is geared to kill the cancer cells and keep the cancer under control. And they are not going to die of their cancer, we hope. No, we still are learning about resistance to immunotherapy, though we do see that sometimes, but not always. Sometimes people do develop long-term immunity. But where we'd like to be is that instead of this being a minority of people, this being the majority of people. And so I think I already alluded to this, that a lot of the study now is trying to figure out the right biomarkers to really get the right people on immunotherapy and not waste time for people who aren't going to benefit from PD-L1 therapies. But the other question is, well, how can we extend the benefit of PD-L1 therapies to other people? We know that alone PD-L1 therapies work by themselves only about 20% of the time, but are there other ways that we can boost people's immune system? Everybody has an immune system, and it's a matter of trying to increase the immunogenicity or increase the signaling of a cancer to say, I'm abnormal, please come and kill me. And there's many ways to do that. We know that chemotherapy, by killing cells, can make tumors more inflamed or immunogenic. Radiation can do the same thing. Surgery can do the same thing. One of the reasons I told you that vaccines may not have been successful in the past is even if you can inject a vaccine into your blood and generate some T cell responses, if you get to the tumor and it has a force field around it, they may not be effective. But if you combine a vaccine with a PD-1 inhibitor, maybe now it can actually really generate killing of that cancer cell in that tumor. and combining with targeted therapy. If targeted therapies are effective drugs but not cures, is there a way that we can combine or sequence with immunotherapy that can make that into a long-term sustained benefit? So those are all things that are being explored right now in lots of ongoing clinical trials, both here and at other institutions across the country and across the world. This is really a focus of everyone's research because we really want to harness the power of using our immune system and integrating it with all of our existing therapies to make them better. There's lots of potential ways to do this, even outside of these combinations, but with combinations of other immunotherapies. And this is something that's been going on now. This is probably ahead of these a little bit, but we know that PD-L1 is not the only signal to regulate immune responses. There are many different inhibitory signals, and there are many different activating signals. And by combining these, we might be able to really boost the chances for immunotherapy to be effective. All of these targets have drugs against them. All of these targets have drugs against them, and they're all in clinical trials. So the number of clinical trials that we're doing in lung cancer to try to develop new therapies has dramatically increased from 10 years ago, where 10 years ago we might have been doing 150 clinical trials in lung cancer specifically. There are probably over 2,000 actively ongoing and enrolling trials right now. And so this just is, again, this sort of hypothetical illustration of where we want to be. Instead of sort of 20% or a minority of people getting this long-term benefit, we want to raise this bar with more combinations, with combining immunotherapy, sequencing immunotherapy with surgery, with radiation, and all the other types of treatments that a patient might experience. So that's an active area of research and opportunities for, I think, improvement across the board. I will stop there, and maybe we'll come back to the questions. Thank you.